Hi.
Hello.
Steve, sorry, technology, up to now, I can't log on to my computer and my assistant also can't log in. And so I guess that's the power of technology. So it's very unfortunate that, we are starting 9 minutes late, but it was purely because of technology. So I don't want to spend a lot of time really reintroducing you. There's a bio of our colleague Steve, but my name's Fred Sawamala. I'm the founding director of the International Center for Child Health and Development. The center, which is really hosting Dr. Steve Weine, who is a colleague of ours, a fellow MPI or director on one of our training programs funded by NIH, Fogate. Just a few lines about Steve. Dr. Stevan Weine is a professor of psychiatry at the University of Illinois in Chicago, the College of Medicine. He also directs the global medicine and the Center for Global Medicine. My apologies, I'm a bit panicking. And for the past 30 years, he has been conducting research both with refugees and migrants in the US and also in post-conflict countries. His focus is mainly on mental health and violence prevention. So I'll stop there. There is a lot written about Dr. that he has written, but there's also a lot that is written about him. He has 2 books, so you can read about those. So I'll stop here and invite Steve to give us his presentation today. Steve, thanks so much for doing this.
Hi, Fred. Thanks very much for introducing me and for giving me this opportunity. Hello, everybody. Good afternoon or good evening, wherever you are. I'm going to launch right into my talk, but I first just want to show you one image because I worked so hard on this. I have a new book out, Best Minds, How Allen Ginsberg Made Revolutionary Poetry from Madness. Intriguing picture. It's actually a photograph from 1948. If you want to learn more, check it out. There's a link in the chat. So that's my shameless self-promotion. But you work so hard on these things, you want people to actually read them. So I'm now going to my PowerPoint slide. Okay, there we go. Can everybody see okay? Can someone?
Yes, we are seeing it okay, only that you may want to put it in the presentation mode. Right now it's in the outline mode, but just do the presentation mode. Maybe if you go down on the far right, right there,
Better?
No, it's still in the outline mode. So you want to do presentation mode.
Yeah, I'm going to stop it. It's presentation mode on mine.
Okay, maybe we share it. Maybe it will show now.
We're getting cursed by technical issues today.
Yeah, technology is interesting.
Now, if I go.
If you go there, hopefully, no, you have it now. That's
okay,
it.
Good. All right. So I'm going to talk to you about this program we're doing in Tajikistan. But first, some images to show you the place and some of my friends and colleagues there. Tajikistan is a mountain country in Central Asia. This is a photograph of Lake Iskanderkul that we took in October. And this is some of the locals. So that's myself and my wife, Laura, and Dr. Gulia Perova there. This is how people like to eat. We're hanging out. That's Gulia getting her PhD. She was a graduate of our D43 program. Gulia's on the left and got a PhD focusing on women's mental health, dealing with issues of violence and things like that. You'll hear more about that. That's Gulia and me and one of the women in our group that you're going to hear about. These are the nurses and peers that were running the groups, and and interpersonal psychotherapy, which I'll talk about. That's John Beck, who is like our program manager and really outstanding person that makes a lot of things possible in Dushanbe. These are, again, a picture of the peers and nurses who ran the groups, really outstanding people. These are some of the women who are in our groups. This is like a focus group we had. This is another woman who is a peer. And in October in Dushanbe, we gave a big presentation. Everybody gathered together and we talked about the experience of this program. That's one of our trainers, Dr. Zebo. People from the Ministry of Health were there and from medical school. So just wanted to give you some images. I'm going to be talking about step care for women's mental health in Tajikistan. There are a lot of people who are involved in this project, of course. It's team science, some of whom I've mentioned on the US side, others, Judith Cook especially. Mary McKay is a consultant. There you go. Chloe Palutnik. So Tajikistan is a very poor country, one of the poorest countries in the world, very isolated. Used to look towards Russia, but can't do so very much anymore. It's one of the highest out migration countries in the world. That means they send a lot of migrants to Russia and other countries. Like 1 out of every 4 Tajik men is a migrant. Gulia and I did a study in a primary care clinic in Dushanbe of women and found that 44% had moderate to severe depression, often with PTSD and anxiety. They reported a lot of physical abuse, lifetime and past year. And, you know, there really isn't much for people with common mental disorders. The little mental health resources there are really focused on chronic mental illness. Psychiatrists there would say that they're schizophrenia doctors. There really are no psychologists or social workers that are focused on kind of like the daily problems of kids and adults. And, you know, like many low-income countries, it's really underinvested in building any kind of mental health system. And yet, you know, we spent a lot of time hanging out there. And I've been working there for 17 years now, I think. First working mostly in the HIV prevention field, but taking notes, observing things regarding mental health. And these are some of the themes that kind of emerged from focus groups and other interviews and observations that we did, that, you know, women have a lot of needs around depression, anxiety, around violence exposure, trauma, needing support, feeling lonely. They don't really know much about common mental disorders or about trauma-related mental health problems. There isn't a culture for seeking psychotherapy or anything like that. They'd be very afraid to do anything related to psychiatry because they thought it would be labeling them as crazy. They do depend a lot on the nurses, who are obviously all women, but they feel like they could trust them and rely upon them. And we also found that in these clinics, there were women who had experienced depression or other kinds of mental health problems, had somehow gotten themselves to a better place and were informally offering care and support to other women. So we took note of that issue. I want to also share a brief story about a woman that I met many years ago that really shaped my interest in this. So this was a woman, well, I gave a presentation basically to a group of psychiatrists and other health workers in which I talked about the experience in America of becoming more aware of trauma as a major issue. And I said that I thought that it would be good if people in Tajikistan would take note of that, because I heard people in Tajikistan kind of complaining that psychiatry isn't regarded with much dignity there. It isn't given respect. They would say to me, it's like a bicycle. It's treated like a bicycle here, which isn't a good thing for them. And so I said, well, one way to get more respect is to address this major social and public health problem of violence against women and children. And they literally laughed at me when I said that. But there was a woman in the back of the room who I could tell was nodding. And afterwards, she came up and said to me, I'd like you to see a case. And I said, okay, thinking she was a nurse, she was gonna lead me to the case. She said, no, the case is me. And then we went and met somewhere and talked. And she told me her story of having been basically molested by someone that she worked with. And she had full-on PTSD and somatic symptoms. She had been mismanaged by medical doctors who tried to give her procedures. She was told that she was schizophrenic. She was not schizophrenic. I sat with her for a couple of hours, did some psychoeducation, taught her deep breathing, and then, stayed in touch with her, and she got better. And that taught me a lot, like, one, that there's a lot of people suffering like her. Two, that there are not people who can say to her what's going on, can educate her, make her feel less alone, and give her the tools to manage her own symptoms. And three, that if you do that for her, she'll get better. So that was a powerful lesson for me. I filed that away, and at that point committed to trying to build something. And that something is what I'm sharing with you today. So really interested in peers as persons who could deliver services. As I told you, these women hanging out in the clinic, in some ways like what this nurse became, though she was a nurse. In peers, I'm talking about laypersons. But what do they offer to women who might be suffering from depression or other common mental disorders? Female solidarity, non-stigmatizing support, and trusted guidance. This is a great asset. How can we leverage this asset? So we decided to try to put together a program that combined peer support with task shifting and a stepped care model. Task shifting, I think you know what that means. If you're in a global health or global mental health context, it means asking people with less training, less skills, and who are less expensive to take on some of the tasks that more highly trained specialists do, like psychologists, social workers, or doctors. It also meant a step care model, and I'll show you what a step care model means, but it basically means you offer the lowest level of care, the least intensive, see if people get better. If they don't get better, a more higher intensive level. If they don't get better, another more higher intensive level. So our step care model incorporates like 3 different evidence-based interventions. The first one, the least intensive one, is a group called Bridges, which has been used in the US to address severe mental illness. We liked it because it was really an empowerment model. It says to women, you need to own your body, your mind, take responsibility for it, and learn the tools to help make yourself better and to help improve things in your life. And so we adapted that from a focus on severe mental health illness to a focus on common mental disorders and other adaptations too. But it's an 8-session group. So let me just say a few words on how we adapted it in a process of, many months of working together with Tajik and American colleagues. So we said that women need to be educated and empowered to be treated for common mental disorders. We pivoted away from serious mental disorders. So we made a real point of saying you do not have a serious mental illness like schizophrenia, which is highly stigmatized. We decided that those groups could be run by peers and nurses because the women were very comfortable with them. And we redefined recovery not recovery like it's defined in the world of schizophrenia, but it's just about believing in the good person that you are. We had to make a number of cultural adaptations, such as the ones mentioned here, and we included great Tajik aphorisms and also things from the Quran in our manual, such as this saying, which I bet you don't know: "Goat, goat, don't die, spring will come." Very Tajik. So we also had different kinds of cases that are or vignettes and cases in the Bridges manual, and we had to change a few things to make it fit with kind of like gender hierarchy in Tajik culture. We were not trying to create a gender revolution in Tajikistan, though sometimes we were accused of that. We also used, as the second step, or like the second intervention, interpersonal psychotherapy, or it's also been called IPC, interpersonal counseling, which, as you know, is an evidence-based intervention, 6 sessions, individualized psychotherapy, in this case, run by a nurse and a peer. And it basically says that if you can help the person better problem solve their interpersonal situation, their anxiety and depression symptoms will decrease. So again, we adapted that. So we made different kinds of example cases, such as early marriage, which is a big thing, or a conflict with your mother-in-law, because a lot of times wives will be living with their mother-in-laws. We also defined this word distress. We really pivoted away from too much using psych jargon, but distress, they could understand it as bad feelings in difficult circumstances. And we talked a lot about trauma. I'm going to move this because it's in my way. Okay. We chose some different kinds of cases than interpersonal psychotherapy typically has. We chose different kinds of role transitions. So what happens when a husband gets a new wife? Polygamy is legal there. That's often a very tough transition for women, for example. So here's the step care model. Women get screened in a primary care clinic by a nurse. We're going from left to right here. They get screened with the Hamilton Depression scale. And if they score 16 or above, we say they have depression. Then they get invited to go to Bridges group, this 8-session group. If their needs are met, then they're done. If they need more, then they go on to interpersonal psychotherapy, which is 6 sessions, again, run by a nurse or peer. If their needs are met, they're done. If they need more, then we give them amitriptyline, starting at 50 milligrams, going up to 100, going up to 150. Why amitriptyline? Because it's available in the formulary in Tajikistan. It doesn't cost them any money. There aren't better antidepressants like SSRIs, but I would argue, do they need the better ones? Like, this is good enough for routine depression. And then if that doesn't help them, then they get an external referral to a psychiatrist. So all of the steps in red and blue are managed in a primary care clinic, public clinic, through the Family Medicine Center by nurses and doctors and peers who are part of that system. No psychiatrists or mental health professionals involved. So actually, this just goes through those steps. So we had an R21 grant to basically develop this and to pilot it. So first, I'm going to tell you the results of that, and then I'm going to tell you the bigger scale up project. So we had 45 participants, and here's how they sorted out. 45 started, and then you could see that 30 of them responded very well to bridges and needed nothing more. 12 got interpersonal psychotherapy, and then 5 got medications. Interestingly, the people who needed medications were people who couldn't attend bridges because, like, their mother-in-law or their husband wouldn't let them go. And so they remained depressed, but they were able to take meds and they got better. So this shows the results of just depression. You could see that most people followed the yellow path. So they started out pretty highly depressed. They got a lot better after bridges. Look at how well bridges performed. And then they kept getting better through wave 4. The people in blue are people who got better, but we thought not better enough. And so we also gave them interpersonal psychotherapy. They're the blue ones, and then they got better. And the persons in green didn't benefit from either of those, but not because they weren't effective, but just because they couldn't attend. And then they got meds and responded. So different pathways towards the same end. The women who participated in bridges said that they got knowledge about mental health, they felt empowered and worthy, they felt greater social support and improved communication. The women who were in IPC also talked about more problem-solving skills and better coping skills to calm themselves. So based on this work, we thought we could adapt bridges and IPC successfully to fit this context. We thought the step care model was implementable by nurses and peers. There were high retention rates. It led to significant decreases in common mental disorders. So we thought this argued for scale up. So we did what we next do in our research endeavors. We wrote an R01 to scale it up. And in this scale up, we were also testing some interesting implementation, dissemination kind of models. And we also included in it some RDoC neuroscience dimensions, which were also in the first study, but I'll tell you about that in a minute. So let me just explain the design really briefly. We had 18 clinics throughout Tajikistan. 6 of them got a comparison control, and 12 of them got the intervention. Those 12, and those 18 were divided between Dushanbe and Sugd. Sugd is a more rural area, Dushanbe a more urban area. And so amongst the 12 clinics that got the intervention, 12 got what we called the clinic implementation team, and 12 did not. So 12 got an extra little benefit of a different strategy for teaching them how to do step care in their clinic. And I'll come to that in a minute. But I'm going to first focus on the kind of effectiveness data of our study. So we did this, by the way, during and after COVID. Remarkably, our team there is just outstanding. I can't say enough. But we're still pulling some of the data together. So I can report to you some, but not all of it today. So we enrolled nurses and physicians from clinics. I'm going to skip over some of these fast. We enrolled peers. How did we define peers? Female Tajik woman, self-identified as a mental health treatment recipient, willing to participate in intervention, training, and delivery. So we assessed 421 women, they entered into the project. 421 got all 8 sessions of bridges. The 72 went to IPC and 43 went to medication. And in short, our results showed decreased depression, anxiety, and PTSD. And that bridges really, again, overperformed. But that IPC also helped with PTSD. So here's kind of how it looks. You could see the solid lines are the intervention, the hashed lines are the control. So you could see, comparing the blue lines, how much depression went down. Green is PTSD. Red is anxiety. Why does anxiety go up? We've been thinking a lot about this and doing qualitative findings on this. I think it might have to do with COVID. I think it might have to do with the war in Ukraine, for one. But we're still trying to piece that together. But nonetheless, still significant differences. You know, a sharper level magnification on this showed some other statistically significant trends. Those who had less depression after the intervention were living with relatives and were employed. Those that had more depression had a husband who was a migrant. As I said, many of the women have migrant husbands and were exposed to more abuse. We also looked at several.
Sorry, Dr. Weine, this is your 105 warning, so about 20 more minutes before Q&A.
Okay.
Thank you.
Yeah, we started a little late, so, but I got it. We looked at some mediating variables, including support and coping, self-esteem, and we found some significant findings, especially in support. Look at how much support increased, but also coping and self-esteem. So now, it's a long story, but I'll just really tell it quickly. You're familiar with the RDoC kind of neurobehavioral function paradigm that NIMH likes to use. Well, we incorporated that into our study. And the bottom line is, the question we were asking, what if there were indicators that would tell you that a person is not going to do well in a group and is more likely to do well in individual work? Well, we think that some of these RDoC predictors could be good for that, especially this one of facial emotion tests. I don't know if you're familiar with that test, but it basically asks the person to look at faces and properly recognize, is that face sad, angry, happy, and they're like animal faces. So we think that it's culturally valid in Tajikistan. And so think about being in a group. In order to be in a group, you have to be able to work and be comfortable with these other people. If you're feeling like everybody's angry at you, you're not going to do well at a group, like this one for sure. So basically, we found some very interesting changes. We found that lower scores on this test did predict less response to the group. So this is from our pilot study. So we're analyzing presently this data from the larger study, and we hope that it will be significant. We also looked at a few other behavioral functions from the RDoC paradigm that we could talk about more if you're interested in. So we did a lot of qualitative work to understand how people experience these interventions, and I just want to share some of the quotes with you. So after the Bridges session, I feel more confident working with women. Now I know how to find the best words, how to find the best approaches in order to help women feel better. So this is a nurse or a peer. Another nurse saying, like, people wouldn't talk about sexual abuse in the group. They felt more comfortable bringing that to interpersonal psychotherapy. Of course, that's understandable. I'm going to skip to this one. Here's some of the things they said about what they learned. Oh, I have these symptoms, so I just have depression. I'm not mad, right? Women learned about mental health to know about depression. It was a surprise for all of them. They're not going mad. They have simply depression, which could be diagnosed and cured. That's a really profound thing, I can tell you, because there are many women who had the experience of being diagnosed with schizophrenia because they had depression and sent to a psychiatric hospital. I'm not kidding. It's like America circa 1940s, which connects with the Allen Ginsberg story, actually. Empowerment. We said this model is about empowerment. Today, I trusted myself when previously my husband said that you will die without me. And I believed him. Today, I say, no, I won't die without you. I'm able to take care of myself and everything would be fine in my life, even if you won't be there. Women saying, if someone else was able to solve her problems, then they could do so too. Social support. I love the group sessions because there we had more communications and learned more from other women's experience. I need more sessions because I like to be among the participants. Women felt very lonely and isolated, especially around these issues. And they felt so much shame, and how affirming it was to be with other women to be able to talk about these in a positive way. I'm going to skip this. I think this is more on interpersonal psychotherapy. I learned to share what was in my mind for a long time and worried me. I could share it with my relatives. I felt much better because of that. So learning how to communicate better. Most of the women could not leave their in-laws and still continue to live with them, though they are much better prepared for life under pressure because they learn techniques of communication and problem solving. Those are taught in both Bridges and especially in IPC. One of the vignettes in IPC was like, your mother-in-law gets mad at you because she doesn't like your cooking. And then that really deflates you. And how can you problem solve that with your mother-in-law? So now I want to focus briefly on the implementation stuff. Remember, we had half the clinics that got a different implementation model, and that was called the clinic implementation team. So in those clinics, an interprofessional team got together that said, we're going to try to make improvements in our clinic on issues related to women's mental health. And so we taught them a bunch of different things: leadership skills, the value of evidence-based interventions, how to do outreach and engagement, things like that. And they got a training. They met for multiple months. They were allowed to talk to the people at other clinics who were doing the same thing. This is kind of the agenda for the different meetings. So a combination of putting together a group, leadership skills, and some technical skills. So we wanted to know, is that going to make a difference in the outcomes? So it made no difference in the primary outcomes of depression, anxiety, or PTSD. Not that we could tell yet. So in other words, in those 6 clinics versus the other 6 clinics, they did the same. However, there's some interesting trends that we took note of, and the most interesting one is in the top line. In the CIT group, only 1 of 14 people dropped out of Bridges. In the non-CIT group, 13, meaning, let me say it differently. There were 14 people who dropped out of Bridges. 13 of them were in non-CIT. Now, I think that's important because if any of you have done group work, there's some people who have more difficulties tend to have trouble going to group, and they need someone to talk with them and work with them to help keep them in the group. And there was something going on, it looks like, in the non-CIT clinics that made that harder than in the CIT clinics. And, if you're doing many of these groups, that could end up becoming a problem as people get fatigue and all of that stuff. So I think that's important, but we're still digging around to understand what it means. We detected no other major differences, except this. This might reflect some of that. So we measured pre and post organizational readiness for change. And these show the pre and post scores for the blue is intervention. The blue is the clinics that got the CIT, and the red they didn't. So you could see amongst nurses, doctors, and peers, there was a higher readiness for change, and this intervention certainly represented change than there was in the non-CIT clinics. I think that might be related to what we're seeing with the higher level of dropouts, but we're going to reflect on this further. Our training, I want to underline how important it was to train these people well. Gulia, who I think might be in this meeting, we'll see when I look into the chat in a minute, was an outstanding trainer, as was Dr. Zabo. And here you could see the women at the sessions learning the manual, practicing. They got about 30 hours training. There are some challenges, but I'm going to try to wrap up. So in the end, we think that it went, kind of better than we could have dreamed of. The model seemed to work. All the interventions seemed to work and benefit people. Very high rates of retention and satisfaction, statistically significant decreases in common mental disorders, and not any bad experiences. So we argued on the basis of this to the Ministry of Health that this should be further scaled up across Tajikistan. The Ministry of Health was our partner in implementing this, as was Tajik State Medical University and Prisma NGO. And so they have agreed. And now this model, I'm pleased to announce, is being taught in every family medical center in Dushanbe, in Tajikistan. And there are groups being held at the different centers, and we have a model of kind of like train the trainer. So the sites that have learned to do this are training other sites. And Gulia, who got her PhD, is on the brink of, we think, getting a position in the Ministry of Health, which in part will be to oversee this, and like an Office of Women's Mental Health in Tajikistan, in the Ministry of Health. Yep, which is kind of what I said here. Another really challenging issue is what to do about peers. We think that this doesn't work without peers. And we want peers to be institutionalized in the medical system. So what does that mean? That would mean them getting some kind of status. It would mean them getting some kind of payment for what they do. We've had a lot of discussions at the level of the ministry. There are difficulties in that. We found a kind of workaround for now. And the workaround is that there's I'm not sure if it's a ministry, I think it might be a ministry level position of like a cabinet of women, and there's a whole women's, let's say, women's support, women's empowerment network within Tajikistan. So the workaround was to have the women be hired there, not through the mental health clinics, or not through the primary care clinics, but they can be supported through this other ministry. And so that's good enough for now. It may not be good enough for the long term. So that's something that we have to kind of continue to think about. Anyways, I'm very proud of our team. We have an absolutely outstanding team from leadership level to the people who ran the groups, and it could not have obviously been done without them, I feel like I'm been a facilitator and been along for this wonderful ride. And I was never so happy as when I was in the room with all of these women and listening to them give testimonials to the profound changes in their lives. I've literally never seen anything like it in all of my history of being involved in different kinds of interventions in the US and all over the world. And I believe it's 100% real. So thanks for listening. I'll be glad to take any questions, and I want to see if any of my friends, yeah, Gulia is here. I want to give Gulia a chance to say something. Gulia, are you there? Do you want to promote Gulia to a panelist? Good. Hi, Gulia.
So Steve, as Gulia comes in, we want to thank you so much for this wonderful presentation. And
hello.
Yeah, okay.
Hi,
I'm
Gulia.
here. Hi.
It's late at night there, but thanks for joining. Anything you want to add?
I want to add that thank you so much, Steve, for you and for University of Illinois, so that we created this team and we worked on this through years, but it's really great for our country, for Tajikistan. So, and everyone has a hope it will spread in villages and different districts. So thank you. It's really great.
Thanks. And maybe when there's some questions, you can give some answers, because you might have better answers than me. I want to say that we stole something from Fred and Mary because we saw how Fred and Mary's work led to changes in legislation around child mental health issues. And also we're working on legislation with the Ministry of Health around women's mental health issues and and around providing these kinds of basic services for women. Something that heretofore does not exist. And it really challenges patriarchal cultural assumptions. Okay, anybody have any questions or comments for us?
Yeah, feel free to either put your question in the chat. I think that's all you can do, because then I don't think that people can speak back. It's a webinar.
There's a question kind of behind the scenes, and then there's a question I always ask, if you don't mind. The first one is, are there plans to kind of look at the greater impacts of, improving women's mental health? What are the kind of wider spread impacts on the community, on families and children, their outcomes? And then the other question is, if someone is a young early career researcher or postdoctoral student and they're interested in this information that you're providing today, what's the best way for them to kind of get into it and make connections?
Mm-hmm. Well, they can email me or call me, and I'll try to answer if that's what you're asking. And maybe they could be in touch with Gulia or some of the other folks in Tajikistan, which is far, far away, but Gulia's here. You could, it's no farther than Africa. You can have exchanges. The first question, yeah, I think that I would really be interested in understanding the impact on children, because I think the women have become better mothers because they're less angry and less impulsive, and they, just as they understand that they need to be cared for better, they understand their children need to be cared for better, and a lot of them understand their own traumatization, and they don't want to perpetuate that. We're actually probably also working towards a project on suicide. There's a huge problem with suicide in a lot of countries, including US, of course. but in Tajikistan, in Central Asia, a lot of suicide, a lot of women commit suicide, not a lot of impulsive, not a lot of suicide attempts, a lot of very successful suicide, and a lot of them emerges out of the same kind of like situation of common mental disorders and family fights and things like that. So we are thinking about adding more of a suicide dimension to this, but it's our goal also, to get this to everyone in Tajikistan, to make this available everywhere. So we're looking to have very broad level impact, and then we're looking to take it further to other countries. And I want to just say, I want to add one more thing, that a lot of us grow up in the world of research where we do studies on one intervention, and we end up thinking like in a one intervention way. But people are complex, people have different levels of need, and one intervention is just not going to cut it, and so I really like the idea of the step care model, because as you could see, there's multiple different pathways to it. You can end up getting 1, 2, or 3 interventions. You can get them in different orders, and it allows for more heterogeneity of needs and of services than just one intervention. So why not think about this model in other contexts too? Certainly in the US, but how about in humanitarian emergencies, for example? I think it would be very, very valuable. We're trying that in other places. Thanks.
Yeah, Steve, there's a question I have. Speaking for people, definitely this is extremely, I think you made a great point of people are complex, the issues are complex. So, you always have to think about these multi-level and very combination interventions if you are going to have a dent in some of these issues. So given that people are complex and systems are complex and you have gatekeepers, so in Tajikistan, especially given that you are planning to take this to another level, who are some of the gatekeepers if someone wanted to do work in Tajikistan? And so where would they begin? Would they begin with the government straight away? Would they begin with non-government organizations? Who are the key gatekeepers that someone should be thinking about, and what kind of systems should they be thinking about?
Good question. Well, you're a gatekeeper for Tajikistan because the Achieve program is sending people there. So that's one place through the Achieve program. But yeah, Tajikistan is hard for outsiders to enter, and I don't take for granted the great relationships that I have with people. Government very much controls everything. So Ministry of Health is an important partner. The medical school is an important partner, which of course is government run. There's an NGO called Prisma NGO that we work with and that we help to stand up, which is which works in partnership with ministry and with the medical school. So I think like that combination of governmental, academic, and non-governmental partners. Tajikistan, unlike a lot of other countries, is not a place of a lot of NGOs because the government has really restricted that over the years. So I'd say at some level, you got to pass through government gatekeepers. So it helped building relationships with those people, understanding what their needs are. And so I would say that at the level of mental health, they understand, I think, or at least the policymakers I've worked with understand the suicide problem. They understand the women's mental health problem, and they understand that the mental health system that they have, which is very old school and very institutionally bound and schizophrenia focused, is not at all the system they need to address these other set of problems. And they're interested in affordable, scalable solutions and they're willing to innovate, but it has to be scalable and affordable. So I
Right.
think if you
So-
can meet those criteria, then they'll work with you.
Okay, I think we are out of time, but there was a student who asked a very good question that why is it, what made you consider stepped care plus task sharing than a straightforward behavioral health model? So,
What made us consider step care and task sharing?
yes.
Well, task sharing because there's a very small number of psychiatrists and they all work in mental hospitals, and we had, peers and nurses who we thought we could deliver the care we needed. So that's task sharing. And step care because we thought, what would happen to these women if they were in the US? They would probably mostly get put on antidepressants. And we thought maybe some of them need antidepressants, but we wanted to max out psychotherapy first, evidence-based psychotherapy. So, we found these two models, and also because we thought that the empowerment model really fit well with the culture and the situation of women in Tajikistan, like I described that nurse. Can I ask Gulia if she just wants to say a last thing on this? Why does this fit well? Why does step care and task shifting fit well in Tajikistan, Gulia? Can you give a quick answer to that before we wrap up?
I think that first of all, it wasn't like focusing, like we didn't focus on mental health, like mental disorders. It was adaptation, like healthcare education without any stigma and discrimination. So people came and participated, like they felt very comfortable. And also it's very like cost effective, I think, what you said. Like for our country, it's not possible like to have this amount of people. We can like teach for a lot of people like mental health education, yes. And give, yeah.
Gulia, thank you, Gulia. I see the question now asked about integrated behavioral health now. Yeah, that's okay. I mean, but that's I think that they may be evolving in that direction. But that's a totally foreign concept in that culture and that healthcare system.
All right, thank you so much. We are extremely grateful for this. I think, we went slightly, just 1 minute over. Thank you very much. Sorry for the issues. I don't know whether Laura wants to make an announcement or Sarah wants to make an announcement before they get off. But thank you so much.
Yes,
Thanks.
thank
Bye,
you.
everybody.
Thank you, everyone. A recording of today's program will be available on YouTube in about 2 or 3 days. I put a link to the chat, and you can register for upcoming open classrooms as well. A link is available in the chat. Thank you very much, Dr. Weine, for sharing your work with us today. Have a great day, everyone.